This is a study of occupational therapy intervention for inpatient stroke rehabilitation by Jennifer Smith. The reference for this study comes from the American Journal of Occupational Therapy, a 2009 article titled Classification of Occupational Therapy Intervention for Inpatient Stroke Rehabilitation. As an introduction, the leading cause of disability in the United States is stroke, and strokes are the most common diagnosis seen by entry-level OT practitioners. And scientific evidence should guide our therapy treatment for it to be effective. As a clinical documentation specialist, my role is to train occupational therapists in documentation that supports medical and functional necessity, that supports the Medicare regulations, and provides for the best practices in patient care. That is why I chose this article to report on for my extra credit project. This study was a non-experimental retrospective record review of the occupational therapy services provided during inpatient stroke rehabilitation at a large teaching hospital that had greater than 400 beds. It was located in the Midwestern part of the United States. This study was conducted on treatments that were conducted between January of 2003 to June of 2004. The patients in this study had physical and occupational therapists. They each had initial and discharge FIM scores. They completed a full course of rehabilitation in a rehab hospital. The ages of the study participants was between the ages of 18 and 85 years old. Each of the stroke patients had a cortical or subcortical stroke diagnosed via an MRI or CT scan, and the excluded patients had other chronic medical conditions such as congestive heart failure, myocardial infarction, cardiac arrhythmias, pneumonia, hip fractures, or a DVT. So the study involved looking at two categories of interventions. The first category was the performance areas of occupation as identified by AOTA that included ADLs, instrumental ADLs, leisure activities, and social participation. The second broad category was pre-functional activities. These were activities that did not involve an occupation. Some of the activities recorded were sitting balance, trunk and upper extremity control, upper extremity therapeutic exercise, and wheelchair management. 3 graduate students were used in this investigation to analyze the OT notes. To reduce bias and increase accuracy, the charts were reviewed a second time by the authors of this study. The data analysis was actually fairly simple. The data was entered in SPSS, which is a statistical software, and descriptive statistics were utilized, including the frequency statistics to classify the OT interventions that were provided in the study. And while these were simple statistics, I think the results were powerful in guiding occupational therapy treatments in rehabilitation facilities. So during the time period mentioned, there were 205 charts available. Although only 80 charts met the inclusion and exclusion criteria. The patients' charts that were evaluated were between the ages of 36 and 85 years old, with a mean age of 70.28 years, plus or minus 11.35 years. The patient race was found to be white. The gender was found to be 51% male and 49% female. That was quite equal. The FIM scores on admission were 71.90 plus or minus 21.47, and the discharge FIM scores were 92.23 plus or minus 24.43. A t-test found that the means between admission and discharge scores were significant at a p-value equaling 0.000. The results of this study showed that the mean length of stay for the patients that were analyzed was 15.9 days, plus or minus 11 days. The type of strokes that were analyzed were primarily ischemic strokes at 82.5%. More than half of the patients discharged home, and a smaller percentage of the patients discharged to skilled nursing facilities. Again, these were just descriptive statistics showing the demographics of the patient charts that were analyzed. For the occupational therapy interventions that were analyzed in the notes, of the 80 patients, there were 1,738 OT sessions. 1,554 of those sessions were intervention sessions, and 184 of the sessions were evaluation sessions. The mean number of sessions per client was 21.73. Here we can see the frequency and type of interventions that occurred. If you look at the pre-functional activities, 65% of all the sessions were used pre-functional activities. And again, those were the type of activities that did not include an occupation. ADLs were included in about 48% of the sessions. Instrumental ADLs only 2%, and leisure and social participation were almost zero. So the type of ADLs that were performed during these sessions, the majority of these sessions involved dressing skills at 34.23%. Functional mobility and grooming were both around 23%. And then eating, toilet hygiene, bathing, and other ADLs were a much smaller percentage. The type of other pre-functional occupational therapy interventions included musculoskeletal interventions. Over 50% of the sessions involved those at 52%. Interventions that were not specifically specified or able to be categorized were about 39.5%. And neuromuscular conditions were involved in less than 20% of the patients. So what do these results mean? The pre-functional activities that were used most frequently and documented most frequently at about almost 66% of the sessions were range of motion exercise and the application of physical agent modalities. These pre-functional activities were aimed to improve body function and to prepare a client to participate in more meaningful activities, although they rarely involved a meaningful component. While ironically, occupational therapy is grounded in meaningful occupations. ADLs were included in nearly half of the session, although mostly basic ADLs were addressed. In fact, upper extremity dressing was the most frequent ADL task that was recorded. Musculoskeletal interventions were recorded in over 50% of the sessions, about 52%, while neuromuscular interventions were only in about 19% of the sessions. And if you recall that stroke does involve the neuromuscular system, yet musculoskeletal interventions were much more prevalent. So what do the findings of this study indicate? OTs use pre-functional activities that aim to improve performance skills and body structures more often than occupation-based activities that incorporate meaningful activities into therapy sessions. Client-centered and goal-directed therapy often increases motivation and participation. And in order, if we increase the motivation, we can lead to an increase in our clients' participation and ultimately a better outcome. I think this has real relevance in the facility where I work, where I find the same results when I'm reviewing charts, that the OTs are primarily performing musculoskeletal exercise, and I strongly believe that functional activities, occupational based activities, uh, even ADL would have a higher impact on our patients and allow them to get home in a much quicker and more successful manner.